actually deliver teaching. They were the first courses.
That was train the trainer.
Train the trainer was the first of those courses. And then that looked at critiquing what you did and everything. So there's always been an emphasis in the UK of supporting the trainer to support you, because that's where the source is. The source is actually, and then the trainer is actually there not to tell you what you're doing wrong, but to tell you what you're doing right and point you in the right direction of doing things that will actually help you improve. So that's how it is looked at in the UK. Now with the advent of more modern scopes, a lot of the time colonoscopy to some people looks quite easy, but it's not, because in Pakistan you guys have scopes that are very modern, but are also quite tiny. I don't know if you recognise it, so on at the PSG, when the Japanese guy Yoshi came up and he sat down to do his procedure and he put the scope in and his face went, oh, jeez. So his face was exactly the same as mine when I came here and did my first ever colonoscopy in 2010. I put the tube in and I went, oh. And it's nothing to do with the patient, it's to do with the scope. The scope in the rectum decided that it wanted to go one way and I wanted it to go the other way. So all of a sudden I had to start thinking, what do we do here? So you're actually remembering stuff that I'd been told 10 years earlier, 15 years earlier, the old scopes helped me deal with your scopes. And he is only used the modern scopes, and that poor fellow's way. I had to concentrate. Oh, I thought, and I felt for him. Afterwards I went up to him and said, your face was a picture. He didn't understand to start with. He said, what do you mean? And I told him, I said, you put the scope in. I did tell you. What I actually told him to do was go into the endoscopy room, introduce himself to the endoscopy team. He thought that meant the other doctors. I meant the endoscopy team. This is advice to you. Right? So go in, get to know your endoscopy team. They're the guys that are going to help you get around. They're the people who are going to support you. They're the people that are going to keep the patient comfortable and let you know. They're the people that you need to do. They're the main resource of your feedback. They're the people who are actually going to get you to do and be the best you can be. So I asked him, I said, told him, when you go into the and introduce yourself to the guys. Talk to them. Ask them what scopes they've got available. Ask them to show them you. Choose the scope that suits you best. He says, oh, they'll all be the same. I said, no, they won't. He chose just to go in, sat there. He said afterwards, I said, I should have done what he said. I said, I weren't telling you just to blow the wind out of my mouth. I was trying to, because when you're doing this live stuff to other people, the last thing you want to do is go, oh. Well, I felt sorry for him, but he says he'll listen next time. It was funny. Right, guys, I don't know where my people are. Where is it? Isaac. Lovely. Let's come forward and have a look. Let's make sure you can get in. So the scopes themselves, anybody recognise them? There's my feet right behind me. So can you pick the scope for me, please?
Okay.
Within 45 minutes.
Okay.
Something.
So which way do you do it? Because I've noticed you do it this way.
Okay, Jordan, we use so humble like I said.
No. This is you. So anything I see, it's you. Don't turn around and say, in Jordan, they do it this way. Right. So he does this. Stop. Oh
not you.
Yes, it's
No one's staring at you. Honestly.
I think that was me.
Now, let's have a look. Let's see. Slightly red, glowing red.
I was trying to stay within the glowing red.
Okay. Happy? Okay. Ah, is it? See, it's that white coat, puts me off. Take that white coat off. Puts me off.
It's finishing. Lele mandi pide.
Who else's hands up? I think it's all fit. You had the hands up.
Asma's hands up.
Do I trust you? Are you going to kick
Do
it
you?
off? So, more of you hold the scope like this than this. What's the advantage of holding the scope either way? What's the disadvantage of holding the scope either way? Anybody know? Why do you hold the scope this way? Don't tell me, Joe.
external as well as taking the pictures.
This
This
is
would be
also-
easier if you hold it
कैमरे के
like
सामने
this.
से इसके
External, external.
कैमरे से
Okay, see the hand?
इसकी आपको बोलो
Right.
वो तो सामने आपको
Okay,
So, why would you hold the scope like this? We have to put it in these and see how it sits in? So you do that. Okay. Why would you hold it like this?
It would be easy in handling, but sometimes maybe external looping it causes difficulty. You have difficulty in moving like this.
Why do you hold it? You hold it. You hold it. So why do you hold it like this?
with more control
It's going again. It's going again.
Easy.
This moment is easy, right?
Oh, there's a head there just behind it.
I think इसको उठा के यहाँ पे
Right, I'll show you. The preference that you will be shown here, what do you think it is? What do you think the preference here is? Umbilical on the inside or the outside? Outside. No,
inside
Inside. Preference is on the inside. Reason being, this is only to show you what happens with the tip. So lock the tip. So when it's on the inside, watch the fingers. See the fingers? The hilt is staying in line with the fingers. Alright? So you just put the finger there. Just pop a finger straight there. Don't move the finger. So when you've got this way, you can do this with the scope. When you've got it here, you cannot do the same. Why?
You cannot do it outside.
This thing is directing
You can't control
your
it.
movement.
it should be inside.
You're nearly there.
You can't control the outside move.
You can. I could make you do it by doing that.
No, not outside.
uncomfortable
What it is that the force is going down here, the torsion force. Whereas when you put it on the inside, it cuts it off, it stops it. So it comes straight away. So if I do the same thing, it don't do it. If you watch the hand, I've not gripped it in any way, shape or form, I just bring the hand up. Just bring it down. Not gripped it. If I do it in this hand, not transmitted. So my preference,
Outside.
inside.
Your hands out there. This one.
So umbilical on the inside. When we're talking about, it's always about the umbilical. Next, fingers. Do we do this or this?
I do this before.
You do both.
Index must be on the upper side and then the middle one. Maybe we need to free the middle one and use the index one.
On the whole, just for normal intubation, except you'll dance with this finger. There are occasions when you'll do this. So what you're doing here is constant blow, intermittent suck. When would you do that? Constant blow, intermittent suck. Constant blow.
Not the constant blow.
Constant blow, intermittent suck. When would you do that?
When we do
We
that,
need to do.
If you do that, it would cause the discomfort of patient because constant air is going
Distension.
inside, so it causes discomfort.
there
of
will be
patient.
deformation and you will not be able to do it. So this
Constant blow, see you're all thinking about advancing the scope, you're all thinking, oh right, he's doing this, he's withdrawing, constant blow, intermittent suck. Constant blow, intermittent suck, if you have liquid in front of you, a large pool of liquid, if you suck down, the whole lot comes down. If you have it on constant blow, intermittent suck, it doesn't collapse.
Okay.
So you can do that. But the big thing that you need to do is remember where the biopsy channel is. So where's the biopsy channel on a colonoscopy?
5 o'clock.
5 o'clock. So when we're looking at it, we need to actually angle the scope tip so it's slightly above the liquid, 5 o'clock, and then that will suck it in, not into the mucosa. So if we suck down completely, the tissue comes up, and when we suck on, we can't clear the liquid. You can put it above, but the best way to actually do it is if you've got a lot of liquid and you don't want to suck the liquid up, is to pass a pair of forceps down so they just appear onto the screen and then do constant suck. The liquid will come past and the mucosa cannot come up and cannot block the channel.
And cause sometimes suction polyp also.
So that will cause suction tension and suction artifacts, but what I'm talking about is you've got a lot of liquid and you're finding it forever, it catches the mucosa. Pass a pair of forceps down so it just appears, only just appears, constant suck into the liquid will come up. If there's solid muck in there as well at the same time, find it difficult to work, that's not going to work anyway. So you have to wash that and dilute it down anyway. So before we move any further, I like this, but on the whole, I tend to do this. This is not wrong. So there's nothing wrong with it. So when we look at the buttons, how does this button work? What button is it?
Section.
So how does it work? So when we press it, how does it suck?
Button, I think, but
Negative pressure
Negative.
inside the fluid inside.
So when you're saying negative pressure, what do you actually mean? Say again.
Inside the face,
So if we take this out, can we see anything? But what do we have to do with the button?
when we push it,
When we press it, now what appears? A hole. So what happens is it makes a noise when the suction goes up. And that is bypassing. As soon as we press this, we put in the suction channel, we open it up. So the actual air, when the suction wants suction, it's sucking through this, the spring. As soon as we push this in, now the suction is diverting the suction power up through the insertion tube and here, through this hole. Now when you look at the size of that hole, that's why the scope gets blocked, because it blocks here. If it's too big to get through that, it's going to block the channel. Okay. Next, what do you do then if something is rather large? You take that out, I give it you, you're going to put your finger straight over there. And that'll suck up anything that will block that channel. So So if your scope's blocked, that's what you can do. That's something you would do definitely with the forceps. If they were there, you could do that. But that will suck up anything. Large, semi-solid lumps. This one, how does this button work? So we've got a noise. So what do we do? We press it. Is that all? Is that what we do? We've got this button and we press it.
If you want to give the air, we will light
Irrigation.
from finger on it.
Right, so how does it
Light
work?
press.
So how does it work? Okay. So if we actually look at this button, can you hear it? Just a little bit of water. So this is constantly blowing air out.
Okay.
So it's leaking air,
Okay.
and that's from this pump.
Okay.
Okay.
Putting it like
So just covering this seals the hole,
goes.
and then it rediverts down into the air-water channel. It's called air-water channel for a reason. Then what do? We press it in. Then it shoots water. How? How suddenly by pressing it do we get water?
Looking in the channel coming from the water.
Well, how does the water know to come out?
Block the air by pressing hard, and then water is connected here. So it's water, so it's coming.
Yeah. So what we have to do is turn this on. So we turn off the pump. When we take this out, we'll see various seals. See this hole? That there is where the air is bypassing it to come out. Cover it, that air then goes straight down the air-water channel. What we do when we press it is that depresses the seal. And now the water passes this and gets pumped down to there. And that's by the fact in this, it's got two ports. One for the water and one for the air. The air is coming out and the water is going in. So that fills up with air at the top, and the water can only come out once this is pressed. That's what that's about. The importance of that? The importance of knowing that?
Sometimes we have to distend that, so we will give the air.
Sometimes it doesn't work, so you need to know how to resolve it. So, what can be wrong?
Sometimes there's no water, that's why.
One, no water. What else? It could be blocked in the end here. That could be damaged by someone smashing the end, because that's what it is here on the end. See the little silver cap there? That's where the water comes out. Direct over the actual lens. These two are the lights, and that's the suction channel.
Sometimes it goes in.
So what you need to do then? What do you do to the button?
Take it out.
Silicon. So then it can go back in. That seals it and lets it sit. What else can be wrong?
Sometimes you just press and it is inside. To take it out.
Yeah, sometimes it just sticks. What else can be wrong?
Connection.
Connection where?
Sometimes.
Right, so that's not holding in right, so that could be here. What else can be wrong? Just done that one. This could be sat slightly out. What else can be wrong? If you look on this, this has two spikes. Bottom spike's for the pump, top spike is for the light. Okay? What else can be wrong? What else?
There is a button here sometimes.
Get all focused. How about this lid not being tight enough? Okay.
So there's some leak.
some leaks.
It's not
Now you're
it's
starting to
actually
think.
property.
So there could be a crack in the bottle. Somebody could have dropped the bottle. And so there's water. As soon as you start to cover this, watch what happens
It's
with
not
the bottle.
some cheap work.
So there could be water then coming and leaking out. So there's a lot of things. So you need to be mindful. The reason for this is that you're going to be back in your senses. You need to be able to diagnose what's wrong. Yesterday, did a polyp yesterday. Everything was working. Bowel distended nicely. Put the snare around the actual polyp. Then all of a sudden, the bowel collapsed. Could not get the vision back for love of their life. Now got the snare around it. Tried covering the snare, it didn't work. Right, so in the end, took it off cold, the polyp. Yes, there was a little bit of blood to say the least. Retroverted the scope, put the scope back, re-snared the actual stone, and then took it off, cauterized it, and it was fine, no problems at all. That wouldn't have happened if the bung hadn't become incompetent. So, but I diagnosed what the problem was very quickly, and we got a new bung, and that then enabled the bowel to actually stay distended. But it's very important to diagnose what's wrong very quickly, because then it stops issues arising. So straight away, accept the issue, accept that what's happening, and then just deal with it. But that's what happened yesterday. It's not an excuse, but what could have done, that would have helped out in the first place, is not be so quick to actually put the snare over. Because I put the snare out, open, and then the bowel was just doing this, and I thought I'd just tickle it just a little bit more, and it did. And it went over. As soon as that happened, the vision died. But maybe not be so quick. But you've got to diagnose what's happening quickly. There's no way of actually substituting it. You had to take the snare off to change for a new one. So, knowing what is wrong with your equipment first, knowing what the solution is, that's the reason for going through this. Next, scopes themselves. Scopes themselves are stupid. Okay, they're the biggest, stupidest thing in your life. Who asked me the question? Well, I think it was you who asked me the question. Just hold the scope there. No, hold it in your hand. Right, so you've got it in your hand, hold it tight. So I've got the scope here, right? It can't go through, it can't go straight. But if I've got all of the scope, how does that feel now?
Is there resistance?
Yeah. How does that feel now?
It's okay, of course.
So
No resistance at
no
all.
resistance. So how I hold the scope, all I'm going to is, you guys will grip the scope like this. Look how it does to the scope. You just grip the scope. Look how it tensions up in the bowel. So if I have this in the bowel, and then how does that feel?
Resistance there.
It's too
So a lot of this is about how you grip it. So I hold the scope like this, and I'll hold it like this.
Not too much pressure.
Don't put too much pressure. But if I want to put pressure on the scope, what will I do?
Finger.
Use the finger, and that will actually make it go straight. That's how I do it. Don't grip it like this, because that then sends the forces every way but the right way. As soon as I grip it, watch what happens to the apex. See? And I'm trying to advance, even if I do this. If I relax the scope, and that, the apex doesn't rise, and there's a different force going into his hand.
This force.
Yeah, if I actually rotate the scope, see?
This force. You are giving this force. Like
Yeah, you're just giving this force. So
Then
this,
you can just solve. If you are just pushing like this, and it is not
We
going
never
forward,
push.
like
Yes.
advancing the scope, then just push it, and if it is not going further, then what will we do?
right, so if you, you look at where your hands are. If my hand is this far apart from the anus, so you hold your hand down there. Don't hold it so tight. So my hand's here. If I'm holding down here, there's a big risk. But that is actually, because it's gripped, it's going to spasm. So I can actually see how tight that is. Now that's very tight because he's gripping it, it's tight. Now if I ask him just to loosen up his grip, just to loosen it a bit more. Right, so that now is normal. So now if I do what you people do, which is this, it will actually go forward, you know, when you're doing this, but this is what happens as well. See your hand up above, see your hand below, but if you actually keep your hand still, come here, keep it straight, it will slide.
That's the important bit. It'll slide this way. The other thing is, if you hold it here, just loosely grip now in your hand. Loosely grip so it'll go down right. So now over here, go up, it doesn't want to go down. We go across to the right, it doesn't want to go down. We go across to the left, it didn't want to go down. We pop this on, do that yourself. Just push it to the right. No finger. Just push it to the right. No, that's forward. Push it to the right. What people tend to do is they'll lift it and they'll push it in. Hold your hand. They'll hold it here. They'll hold it here. They'll hold it here. They'll hold it here. Now, if you put your finger straight onto the top, down, advance. It's catching down there on the track. So that's how you do it.
That's correct.
Okay. So when we're looking at the mannequin itself, you're wondering what I'm looking at the light. You see it's flickering. Now you guys are going to want to wear gloves if you can do all this stuff. I tend not to. The only time I'll lubricate here is there now. So I definitely wear gloves in the normal case. The reason what I'm showing you is that my hand's got gel on it now. You'll see on my hand slides. So the scope goes in. The scope is there. So the scope goes in. I've got gel on my hands. Always, you should really, in all honesty, try and make sure that the monitor is in front of you. So that you ergonomics. Little wheel, neutral. When I say neutral, it's in the 10-2 position. 10-2 position. See the fold that's in front of you? So what we can do, anti-clockwise, is advance the scope. Clockwise just over. Now if you see this now, a lot of people who now want to go clockwise on that. I tend not to. I tend to go anti-clockwise. Bring the scope completely round. And then tip up. That's what I tend to do, even in the real case.
Some go outside, then you will
Yeah. And then as it goes forward now, the loop come out, as it does this, and then the scope will then eventually go straight forward. This is nice. So anti-clockwise. Comes to this point, the clockwise toe come in, tip up, tip down, and you forward. Okay? Now you've gone so far, 25 centimetres. Stop, draw the scope back. This is a mannequin. We don't go all the way around because the mannequin itself will have resistance in it. The other issue is that we don't need to get round. The end cap is not the cecum. Here is around where the cecum is. So if you notice on there, all we're doing, we can steer the scope, so we can steer it, make sure it stays good, go forward, stop, draw back. Now the scope's starting to get stiff again. So now, I tend to do this. This is what I do. Doesn't mean this is correct, but I get gel on my fingers, and then I'll pass the scope. How much gripping am I doing on the scope? I can't do it a lot because I've got gel on it. Can you notice? Clockwise torque again, draw back the scope, let it come back, tip up. That's it.
So this depends on the by some means, okay. Also the looks depends by anti-clockwise or
It's not just about going. A lot of the time, you guys just see the lumen, and you'll go straight in, straight in, straight in, all the time. That's what you want to do. Straight in, straight in. For some reason. Yes, please. there's the scope. Now, can you see how much is there? That's not how that would work on the on this leg. So that needs to be crossed. Here says how many loops. So it's 7. 1, 2, 3, 4, 1, 2, 3, 4, 5, 6, 7. This is on constant flow. So what we've got, scope, neutralise the wheel, draw the scope back, clockwise scope. Draw the scope back, and then you can advance the scope. You never just keep advancing. You see the lumen, stop once you've negotiated something, and then you can actually then advance the scope. So here, change position again, and advance the scope. The mannequin will find it very difficult to get beyond the corner because it will want to do all sorts of things. This is blowing up with chest. Sometimes it's over for some reason. Oh, it kills you to say it. It doesn't upset him saying it.
Is it necessary to be both anti-clockwise while inserting? Or if you go clockwise?
I've just shown you. So I'm going to ask you, these guys to go in now.
Okay, while you are moving, this is the clockwise for the line. Then
Yeah.
okay, you can do it clockwise.
You can do it clockwise, you'll lose them all. You'll definitely lose them all. So going
You
in.
can do the two look outside, then you can touch it inside.
So what have I shown you that's different to what you do? What have I actually shown you that's different to what you do? What have I done and shown you that's different to what you do that day? What have I done differently to what you do?
Okay, you have to remind to
Starting from the way we hold the scope,
Yeah.
the way you are holding it really differently, and that creates problems for us. Number one is that. Number two is that the thing that you hold is that for anti-clock, that's why we feel more familiar, because most of the time we when
Initially in the rectum I've gone clockwise, but it's when you've gone to the proximal signal. No, not proximal signal. Proximal rectum, you've got distal signal, I've gone anti-clockwise. As soon as you come clockwise, it then drags the scope up. You let the scope take it through. If you're wondering what I'm looking at, I'm looking at the monitor behind you. I'm looking at the monitor behind you. If you're wondering what I'm looking at. So you go here, anti-clockwise, and come up, and let the clockwise come in. And as the clockwise comes in, it takes it straight.
Question, can we take the position of patient while we are entering the sigmoid from lateral to supine?
Why?
So because it would make the sigmoid more straight.
No.
No?
Well, what's the advantage? If there's an advantage, I'll say yes.
Because if left lateral position, we are turning the scope anti-clockwise and clockwise. At that time it makes loop.
Okay.
But if it's straight sigmoid, then the loop would be not there.
Medic. Are you a doctor? Medic? Surgeon? Medic? Medic, 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 medic. No medic, no surgeon.
You're a surgeon, no?
You're a surgeon. Okay. Years ago, they used to get the patient on the front to start the procedure, in the belief that the sigmoid then fell forward. How does that sound?
He's asking, does it sound real that if a patient is changing the position, then sigmoid is also changing the position?
I think supine position, I think the ingulation change the sigmoid.
When you change position on a patient, you change position here. I put the scope on the back. Yes, the position has changed. It has changed by the fact that I've now put 90 degrees of clockwise tilt on the scope. I put the patient on the back. When I put the patient from the back to the left, I've now put 90 degrees of anti-clockwise tilt on the scope, without touching the scope. Because I've done that. If I put the patient on the front, I've now put another 90 degrees of anti-clockwise tilt. Because I've done this, instead of doing this. What you're talking about is, once you've gone through the sigmoid, is there any advantage of putting the patient on the back? What I'm going to say to you is, why do you want to move the patient if everything is going good?
When everything is not going good, especially left and right, I'm going from right and while I reach I'm about to enter the sigmoid and there's so much angulation. So I want to decrease that angulation so I can keep the patient supine so that maybe it will be practically what I have seen.
The best way to actually put a patient, if you're actually going to do anything, you put them in the right. And that enables the sigmoid to drop down if you actually were going to believe any of what they say about moving the patient around. Because if you put the patient in this, and we look in here, we see the sigmoid will drop down. So if you're going to do, but do remember that there's a lot of other things that stop the stomach coming forward, or not the stomach, the bowel coming forward. And that can be the fact that you're a fat porker like myself, and that actually retains it, so that will sit back there. So the issue that you've got, this is funky, look. See? I sucked all that out a few moments ago. So what I'm trying to get you to look at, moving the patient can work, does work, and you will be doing it while you're here. But it's not something that you'll do automatically. Okay. So expecting that, right now we're in the sigmoid, now we're going to put them on the back. Now we're in the, coming up to the spinal flexion, now we need to put them on the right side. Now we've gone round the spinal flexion, we need to put them back on the back. Now we're coming up to the hepatic, we now put them back on the left side. Now, we're not going to do it. One, it's a waste of time. Keep going as long as it's safe to go. Then when you're no longer safe to go, then look at it. What are your options and what could you do? If that means change position. But the first things you're going to do is look at your scope, look at how you've got things, look at where the angulation is, look at where the direction is. What is it that's stopping you going forward? Is it a loop? Is it X, Y, and Z? It's not necessarily about what position the patient is in. This is the last thing. What that does, it starts you again from square one. Once you've eradicated the other things that you've worked with. So it's stop, pull back a small distance, 2-3 centimetres till you've got a view. Suck down, that doesn't mean completely collapse, it just means make the patient feel comfortable. Suck down so you can see where you need to go. Pause, make a plan. Discuss, make a plan. Then, with that plan in mind, attempt to execute. If that fails, stop, pull back, suck down, discuss why it wasn't successful. If it wasn't successful because you didn't commit, retry. If it was because of some other things, then we may then have to consider what the options are. That then might be, shall we change the position? So it's not changing position to me is not the first thing I'm going to do.
Okay. You know, what about the pressure?
Abdominal pressure?
Yes.
Okay.
Can we apply initially on the while decrease the chances of loop?
Okay, so let's give you a clue. Right. I've got this scope here. I've got the patient to the left side. I'll pull this back. Now you apply sigmoid pressure. Apply sigmoid pressure. Sigmoid. Right? How the hell am I going to get through that? So you just let go. You apply your sigmoid pressure you want to apply.
Yeah, including the.
Now you crush that. Here crush it much more.
So what will happen normally is that someone will apply sigmoid pressure. They'll bring the sigmoid pressure in, and then you're never going to get through. There's none of this where you're looking at that and you're thinking, oh, I can feel it, I'll let go. Oh, I can do this. Because that's what you did. I knew you were doing it because I watched your arm. I could see your ear was relaxing. That's not how people apply pressure. So asking someone to apply pressure right at the beginning, no. That'll turn it off the loop. Asking someone to offer you support pressure, pressure to me, if you're going to apply it, hip transverse is when it starts to come into play or just proximal to the cecum. And rather the patient roll to the front, so that causes a unilateral all the way up here. Unilateral meaning on its own and its own support. So that goes there. Right.
So when the crush is not, if you are going to small, it's better to give sometimes water and see air. Or you prefer.
Okay. So if you're talking about underwater, I like underwater because underwater we can spray a lot of water in and relax just about. Now some people are saying is there a difference between warm water and cold water? There isn't a great deal of difference, but I have found that cold water is good when you've got a bleed. It actually slows up anything to do with blood, causes the vessels to contract. With regards to bowel, I found warm water actually reduces spasm. Spasm is the issue. But if it's just normal bowel and you want to go ahead, minimal air, you'll still need to tap the air every now and again, but you will actually be able to get around very successfully just using water. I like that.
You start using water from sigmoid or rectum?
Sigmoid, not rectum. You fill up the rectum, then the person will evacuate very quickly. You fill up the sigmoid, then eventually the person's going to evacuate again. So I'm going to use it when I have to use it. Again, it's like you were saying, at this point do I put them on the back, do I put them on the side? No, I use it when I need to use it. So if I come across an area that I think is causing spasm, I'll use it then.
Sometimes we find this mucosa very dry and sticky, so we use water in this situation. If this is very dry and sticky, the mucosa, put on. Because if it's
Not an issue. Not an issue. You can use it quite safely.
But we should not at the first instance.
No, if you fill the rectum full of water, that water's got to go somewhere. And normally it's all over the bed and all over your shoes. That's just thinking of you, but I'm just thinking of the patient. They don't want to, they don't want to be relaxed. Right, candidates. Yes. What do you do first? Check it. Lady first. You can wear gloves. Oh yeah, you can. Right, one thing we haven't touched on, stiffness. I very rarely use it. I probably will use it during the course just to show you. But if we apply the stiffness, what part of the scope does it stiffen? Stiffness, what part of the scope does it stiffen? The whole length?
Proximal, distal.
Where?
Maybe to here?
So from here to here?
30, I think.
Just below the big hand.
Okay.
I'm not sure.
I know how to use that.
Below the big hand.
You should know.
I'm not sure, but I think the middle part.
So what's the middle part?
I think from 40 to 80 or 90. I don't know.
He knows.
Distal, the 30.
So you're saying from here to here? You're saying from here to here?
Or I think distant.
Hands up those who are right. Hands up those who are closest. So it's actually from here to here. So let's show you. Here's the scope. Yeah. Stiffness was about trying to get you through the sigmoid. So why do I want to stiffen up the tip? Stiffness was about getting through the sigmoid. So why do I want to stiffen up for the splenic flexure and the sigmoid?
Stiffness is for not for the transverse scope.
Crossing this pretty flat.
Now look at it. So you take the stiffness off now. Take the stiffness off. Watch the scope. In comparison. Put the stiffness back up. And that's not me making it up. Feel the scope. Gently between your fingers and just push it in. Now take it off. Put it on. And it's here. Not about here. Okay. Transverse colon and all that stuff. It makes you feel good.
What about the, it should be gradual increase in the stiffness or just whole at once?
So you have a light switch in the room. Do you have it on dim when you walk in, or do you like the light to see where you're walking? I like to see what I'm doing, so if I was going to apply it's either on or off. If you talk to the Japanese guy, Yoshi, he says, I always start, right, let's have a look. There we go, right there. I always start on one. He always starts on one. It's absolute Jackanory. Jackanory was a story program when I was a kid. Start on 3, that's when it starts. So I either want it or I don't want it. That's my opinion.
Actually, okay, so that's
Where should we use stiffness?
If you're having loops in the sigmoid.
So we need to use it when
Well, just explain it in 12
I don't know what is I actually don't know.
It is used to help people to try and keep the straight scope down. Leave him. Leave him. Let him work it out. You guys, I know you're helping each other, but I'm letting him work it out. This is a guy who's self-taught. So what I want you guys to know is, yes, you knew what the problem was. Okay? We're going to show you other issues with the scope and the processes. So these are things you need to start doing. So there you knew what the issue was. What was the importance of having the image frozen? You're in Pakistan. What is the importance of having the image frozen as you're doing intubation?
privacy.
Privacy.
Why don't this be before holding the scope?
Privacy. Freeze the scope before you introduce the scope, hold the scope, switch, then you can unfreeze. So it's done on purpose.
So you prefer finger guided insertion or just at the 30 degree, 30 centimeters?
Finger guided, you want to go with the scope?
Yeah, you prefer a finger guided insertion.
You need a finger on the scope at the
Finger
same
with the
time,
scope.
going in at the same time. Okay. Why would you want to put so much in someone's bottom?
Not at the same time, but I think some people hold their scope at the 30 centimeter, and sometimes some people hold it in the closer, which is more preferable.
His question is while we are putting in the scope, where should
Inserting
we
the
hold
scope.
our
Oh, right.
at 30 centimeter or near the thumb?
Comfortable finger guided.
पता नहीं लगेगा फिर हम सुंदर ऐड करते हैं कुछ बीच में करना वो
इंसर्ट तो नहीं करते थोड़ा पीछे.
Little wheel meets the neutral. Let it rotate again. Not the wrist. Right, so what are you thinking of trying to get you to do? I'm trying to get you to keep the wrist straight. I'm trying to get you to keep the shoulder straight. I'm trying to no. I'm trying to get you to keep the hips straight and everything else straight. Neck straight. What do you think I'm trying to do? Injuries.
Ergonomics.
Yeah, ergonomics. So, you ask Sarge what he's got wrong with him at the moment. Right? So Sarge's got a problem with his neck. I've got a problem with my neck. I've got a problem with my back. I've got a problem with my hands. However, I've been scoping like this. This is from the early days. You guys, if you continue scoping the way it looks like on the scope, you will get the same issues. Draw the scope back a centimetre. Good. Where do you think the lumen is? What makes you think that? On the left side. What makes you think that? Because it's more 11 o'clock. Now it's at 12 o'clock. Yeah, it's here. Tip on. So what made me think that? Right, let's critique the image. How do we know which way to go? How do we know?
Direction of force.
Forward. Yeah, that's one. What else? Yeah, sometimes you follow. What else?
Shadow.
Shadow. Okay, shadow. What's the importance of the shadow? This is the same in the human being. So what we've got here is shiny. Right, so you're very close to the mucosa. See where the mucosa is lost? See where the light is lost? That the light is lost into the lumen. So it's actually you tip up because you're going to the dark side. So when you have a loss about where to go, look and see where is it the most bright and reflective? That's the mucosa. Where it's the least reflective, that's giving you a suggestion. You see the folds here? The folds here. So what the shape of this? Semicircular. Okay, let's keep it even more simple. Right? The shape is very consistent with the boat. So what do we do with boats? We go over the water. So what do we do when we see something like this? That tells us we need to go over this. Okay. So when we come to something where it's like this, that's like a bridge. That tells us we have to go under it. So we go under bridges and we go over water. What would the importance be if we saw a lot of liquid here? What would that tell us? No liquid here, but lots of liquid here. Right here on my hand. What would that tell us? So that's, and what's the importance of knowing that? No?
So that is most probably the shining color.
No.
Direction of the scope.
So it's telling me in this position, if that was there, that would tell me that's the left lateral. Right? But what's the importance of it?
If you see rectum, then you can come
No.
to know the
No.
anatomy of
Already
rectum,
said no.
superior wall, inferior wall.
I've said no.
Okay.
It directs the lumen.
What's the importance of it?
We are near the
Towards direction, towards that side.
No. Okay. What happens if we... The importance of it is to know which way is up and which way is down. Now, if I'm going to deal with a polyp, which way is the blood going to go if the polyp starts to bleed? The blood is going to... If this is where the water is, which way is the blood going to go? It's going to go down. So where do I want the polyp?
At 6 o'clock. Position of 6 o'clock.
I want the polyp here. So if it loses blood, it can drip down here, and then it gives me time to actually keep my eye on this. So the importance of where the water is tells you an awful lot. If there is no water, what can you do? You've got to take off the polyp. Slowly inject some water. You inject it quickly, shoot it right down the valve. You put some water in slowly, watch where it goes. That tells you where the polyp sits. So you can rotate the patient, or you can rotate the scope. Right, so if we've got fluid here, for example, and we've got a polyp, we don't want the polyp here. We want the polyp at 12 o'clock. So what we would do then is that we would rotate the patient so that then this polyp would come round and wouldn't be in the fluid. If the polyp was here, if we actually put the polyp off and we were feeding, the blood would come up and cover the polyp base, so we couldn't treat it. We wouldn't see it. So we need to keep it exposed. So wherever the fluid collects, we need to rotate the patient or the scope so that the polyp stays away from the fluid. What I'm saying to you is, if you get a brisk bleed and take it off a polyp, that will fill up that area quicker than what you put your water in. So what I'm getting you to think of is, how can I make it as safe as possible to remove a polyp? So keep them away, make sure that the scope position there, 5 o'clock, if this is liquid, I rotate the patient so the polyp sits here and it's still at 5 o'clock. But the liquid will now be over here. Either by rotating the patient or rotating the scope. Thank you. Next. I want to do knowledge of the course, that's why I took it up. I understand it. You forget. Well, you'd be very stiff if you were trying to push it through their pubic region. Right, so you scope, stop, okay. Now look down, you scope it up there. Let's move this up here just a fraction.
Thank you.
Bring this here, and look straight. Let the scope sitting down.
Let the scope sit in
Grab back. Stiff. Right. Let the scope go. Let this hand relax. Yeah, stop. Let the scope relax in the right hand. Let go of the right hand. Let go. Let go. Let go. Let go. Let go.
Okay.
Let go of the scope. You don't have to hold the scope. Good man. Keep the scope on the bed. Down. Down. Understand, turn your shoulder. Now big room. No, too much. Now big room. See?
Here's the look. I don't have one position.
Stop.
Okay.
Stop. Look at where again you pull the scope off the bed. You keep pulling the scope off the bed. Okay. So just be mindful. What you're trying to do, just pop it down. Pop it down. Let go. Right. Step back. The scope is not going to go anywhere.
Okay.
Right. If you look where the scope is, see how it's got a lot of tension in it there. If I pick the scope up, right. So here, what you're doing is that you're causing the scope onto the bed, off the bed, so you're getting this effect. And you're losing any torque what you're trying to do. It's not trying to grab the scope. The scope will come back. If you're trying to grab it, you don't want to. So this does not have the same effect. Look what's happening. It doesn't have the same effect. This, keeping this here and relaxing, this, by keeping down on the bed, has the effect. Look at that, 50. That has the effect. Look. That has the effect. This does not. I've taken out the loop now by just introducing that. You had a loop inside there. How did I know you had a loop?
Because there was no one to one.
No. How did I know you had a loop?
There is stiffness in the scope.
How do I know the loop's out there? How do I?
Just reading.
One-to-one movement.
One is lost. And also position of the scope.
Remember the scope is here? Remember the scope is here on its own? Do you remember the scope was here on its own? And then down, as I did that, and that stayed in the same place. As I did that, the scope now relaxed and gone back down there. So the loop has come out.
Okay.
So when you've got loop inside the patient and it's stiff and locked up, that will also affect the outside, and this will be stiff and locked up. So what you do is that you come and you take the loop out. You're focused on there. What you need to be is slow down, get your finger and look at where the scope is. Hip across, and then where the scope is. Slow down. That's all you need to do. See, simple. Now that wants to go clockwise. I don't want it to go clockwise, so we'll go anti-clockwise.
Okay, one question.
See?
Some people we hold the hand cross sometimes.
Okay, so when you want to go clockwise, you put your hand under. That enables the support to go forward. When you want to go anti-clockwise, let go.
The opposite. Okay.
Hold. Hold it. When you want to go anti-clockwise, but you see all the time you're pulling through one small area of the bed. You're not allowing it to go through a large area of the bed. The large area is like a snowshoe. What I want it is like an ice skate. So that now causes least resistance on the scope. That's what you want. Crack on.
I was thinking that you go clockwise because the lumen was towards one. Why anti-clockwise?
Move the sigmoid forward, go forward, let the scope relax, draw back, and flat sigmoid straight.
You're making some of your hands.
Anti-clockwise. Oh yeah, you can. In the first couple of folds in the rectum, you will then go forward. You may think you command my time, but my wife commands my time. No, you're in trouble.
Just asking how long you think this will take.
Well, when do you want us to finish?
12 o'clock.
Easy.
Easy?
Easy, half 11 as you want.
11:30?
11:30. Done.
How many candidates do you have left for hand?
1.5.
Okay. I'll get the patients in the room by 11:30 then.
First patient in, who's up first?
Should we take 2 candidates at a time? One could be transmitted, the other could just be...
Yeah.
So 11:30 I'll be ready with the room. Yeah? Then you can just call them in as soon as you're done. Even if it's by 12
Tell me
o'clock.
what he should have done. Yeah. What should he have done?
First study was not holding the scope properly.
Right. Be more. So he's not holding the scope properly, boss. What do you mean he's not holding it properly? Tell me out. Tell me what he should have done.
Other issue was that he was creating the room, but he was unable to.
So how should he hold the scope?
He should hold it like 15-20 centimeters.
So like this?
Like this.
Okay. What else should he do?
So that he may transmit the force properly to the tissue.
So what he's doing is he's really losing himself when he comes to all of this. And he keeps flicking up and moving. See here, this is where his problem is. Anybody got any idea what comes next? Now, I know you, and I know you're not going to be bothered by doing it, so you and I are going to play. So watch. Look at me. Right, straight down. Just look how wonderful I am. Oh, do you see this finger? Need glasses? No, you're squinting. Alright, come round, otherwise you... Come round. I can't tell you that, it's embarrassing. Come round. Come round. Hang on, mate. 11:30, you're on the field. Right, this is in front of his eyes. He's looking at me all the time. Right, tell me when your finger disappears. You're not following your eyes, keep looking at me. Tell me when it disappears. What I have in the finger? You see the finger?
Now it's disappeared.
Okay, so it's there. Can you see where it is? Mid-forehead. Finger, when it disappears. When it disappears. Right. Top lip. What's that telling you about the skull?
The lens.
The lens.
How much you can see by that?
So what I'm saying is, just because you lose the vision of the fold, which is in front of you, doesn't mean the scope can go past. Just because you can't see the fold, this is where you're thinking, I've now tipped it up, I've tipped it down, so now I no longer see the fold go forward, and it won't go forward because of this, you capture the fold. So when you do it, you've got to exaggerate the movement. You've got to slow down. So when you come to a fold and you're going to go under it, just because it disappears doesn't mean you're going to clear it. It means you have to duck a little bit more.
Okay, how to go down a little bit.
A little bit more to stop the catching it. But that's where you're forward to.
Okay, thank you very much.
Next, who's next? Any questions? Are you enjoying
Whenever
it?
there is a fold, we have to sit down, break it down. The fold.
We'll show
No,
you.
no, for now, you didn't get
Any other questions? You're very quiet.
No.
one question. Where should we use small wheel while doing it?
Right.
And do we need
Diverticularly, yeah, you flip the little wheel every now and again. The little wheel is just to cause minor deviations of the tip. It's not to be relied upon. Two-handed colonoscopy where you take that hand off there and put it on here, that's frowned on. I don't like that. So I will keep an eye on it very carefully for that. So it's something that you need to be aware of. So
we use it
telling
here.
you to move.
Yeah. What about lock?
Right. We'll come to that in a minute. What? Oh yeah.
सिक्का उसमें TI में जाने के लिए.
sometimes yes.
Should bring this forward. Sit down, just by bringing this forward.
What about lock?
And that's relaxes your shoulder. I did it without it. So you complain. See, I do it on purpose because you guys then start complaining, and then I say, well, I did it without it. And I can do this, and I can do that. So, look. Now, stop. See how you're coming in from there? Right, you push that backwards, you're going to cause pain in the body. So what you're going to do, watch the screen. Let the scope relax. Let the scope relax. Now, middle wheel back. No. Hold the scope. Hand underneath. And that's it. Just by putting your hand underneath, took that central. Simple. Good. All I'm asking you to do is get used to the concept. Yeah. It's not about getting around on the mannequin, it's getting used to the concept, used to the idea. Okay? Relax. What's he saying? You're not listening. Right, who's next? Yeah. Yeah, me. How was that? Any questions? Different. And once you look to it, because we're clockwise talking, you're looking at how to make it work for you. Straight. Go on, B. Hand down. Right hand. So when you want to do clockwise, it goes under. When you want to do anti-clockwise, it goes over. Anti-clockwise, you can open the stance. Clockwise, you can close. So all you get used to is how you do it. See how you get this go? You're going to the back and you're going over. So you have to keep it straight, go back. Now, come back, you might do. Keep going forward, no, you keep toe on that big meter. Your toe on that meter. Let the anti-clockwise come in, so it's hand over the top. There you go. Okay?
So one thing that I feel that I use is
The big wheel. Yeah, you should. The big wheel should be used a lot. The big wheel should be flagged up. So just to conclude this session, just want you to have a think about how... Oh, you said you hadn't.
anti-clockwise over, clockwise reverse.
Clockwise and anti-clockwise. Yeah?
Thank you.
Hand is forward. Your right hand is forward. So you need to drop your left hand now because you're putting anti-clockwise torque on the scope. This comes down, this stands up, this foot is back, that foot is forward. Not too far apart, you're not John Wayne. mannequin side, we'll stick a little. Anti-clockwise very much. Remember, you've got to exaggerate the move going under the fold. Good. Good. Now with the anti-clockwise. Yeah? Stand up straight. Show the square. Good. Stop like that. How did that feel? How does that feel compared to how you normally do? When I've watched you, you were holding the scope this way, now you're holding it this way. When I was watching you before, you'd hold it still, when you were like this, and now you're doing... Okay. So just now, what we've got is one more thing. Don't take the glove off. Stand there with that line. So you're like this. No, no. This way. That's good. And you need a clear walk back. Do you think you got a clear walk back? If you haven't got a clear walk back, it's her fault. Right. You can keep your eyes open for this. Normally I'll get you to close your eyes. I'll just go here. Right, what I want you to do, hold the scope again. Right, I want you to tell me how it feels when you apply a clockwise tolerance. So apply a clockwise tolerance. Now you tell me how it feels when you apply an anti-clockwise tolerance. Okay, so if I was to say to you, you've got a loop, the scope is not going forward. So I'm going to say to you, keep your hand here, take a step back, so this state, take the hand with you. When it feels that it's tightening up, stop, then apply anti-clockwise to it. When it feels like it's tightening up. Right. Now how does that feel now you're applying anti-clockwise?
Anti-clockwise.
Slowly, come off. Now clockwise. How does that feel? Right. So what you want to do is slowly, ever so slowly, apply an anti-clockwise to it. Stop. Walk back. Check the scope with you. When it tightens up again, apply anti-clockwise to it. Apply clockwise to it. How does that feel? Slowly apply anti-clockwise to it. How does that feel? Okay, walk back slowly. If you can't get back safely, it's her fault. So more anti-clockwise. More anti-clockwise. Walk back more. And walk back more. Get the scope straight. Walk back. If you can't get there, it's her fault. So from here to there, see the distance?
Yes.
So we've got a loop. So what does that tell you? Huh?
Go backward, reduction and do the anti-clockwise turns.
What does that tell you?
Take all the colonoscopy segment, can be trans. So if you do this clockwise, you can straighten it inside.
What does that tell you?
When you are delooping the direction which you have, whichever you have applied, whether it's clock or anti-clock, if you feel more stiffness, then you should do it in the opposite direction.
Okay, in getting him to do what he's done, what does it tell you? I got him to do something, we reduced the loop, but visually, what did that tell you?
Actually, what I understood from this thing was how to de-loop. The direction in which we have formed the loop, we should de-loop it in the opposite direction. This is what I understood.
Is it for the alpha loop only?
Don't give a monkeys if it's an alpha loop, a beta loop, a gamma
Draw
loop.
along with
What I said to do was put the clockwise torque on anti-clockwise. He didn't know, even though he could see it, that's fine. But all he was doing was feeling which one felt more tight when he actually applied it. This is how you reduce a loop. You feel the least resistance. That's how you reduce a loop. All this gamma, beta, flamma, flema, whatever you want to call them, I know what they call it, by the way. But it doesn't matter. It's the least resistance. What else? The most important thing did that thing show you? Here we go. We're on the right tracks now. What did it show you? Not walk away, but how far did he walk away? So does that show you, you've got a loop, how far you have to reduce the scope So that is just a visual for you to remember. That doesn't mean, all right, now the shoulder's in the end, the shoulder, we have to reduce it to it. Oh look, there's the tip of the scope. That's like, no, what I'm trying to get you to understand is you need to reduce a loop more than what you think you're reducing. So a lot of time you'll reduce, oh, it's not reduced. It's because you've not come back far enough.
You have to reduce it slowly.
Till you
Yeah.
feel it.
Okay, at the area.
You have to reduce it slowly, controlled.
Okay.
You come back slowly. Now, why did I get you to do what I did? Because if you've got a loop, this is the patient, you've got a loop. You're taught to apply anti-clockwise torque. Look how much space that takes up in the patient. So if what I got you to do is apply the torque, stop, come back, tight, clockwise, anti-clockwise, stop, clockwise, anti-clockwise, stop, clockwise, anti-clockwise, stop, clockwise, anti-clockwise. So you don't take up all this space in the area, you don't cause the stretching of the mesentery, you cause them least discomfort, not pain, and that's what it's about. So, one, you have to, when you're reducing the loop, you have to come back further than you think. Two, when you're doing it, it's an on-off, slow movement. Three, it's controlled. If the tip cannot see the lumen as you reduce, it's got nowhere to run to. So when the scope reduces, all of a sudden, it wants to go somewhere, but it can't, it's got nowhere to run to. If you've got that tip against the mucosal wall, the only place it can go is into the mucosal wall, and that's where you can cause a perforation. Tip perforation is the most brutal perforation of the nail. If you cause a tip perforation, you're a barbarian. Okay? So, we made it.
The resistance uses
You'll feel wherever's the least resistant, that's the direction you go with the torque.
Okay, the base system, you go with and stop.
Yeah,
And try to maintain the same amount of time.
absolutely. Right, so we're ready.
Which two candidates would like to go first? Okay, so you can go into endo 1 and you can go into endo 2. Our and supervisor, Dr. Mansur, Dr. Azad, endo 1, endo 2 में patient भी ready.
Right, thank you. Candidates, right, we can continue to go through this, not a problem, while they're in there, but I'd rather you watch what happens in the rooms at the moment so we get an idea. The idea of having this in here is that we can revisit, we can come back anytime, observers, candidates yourselves, we can come back to this, it's not a problem. What I'd like you to do is look at some of the procedures where I'm going on to start with, then we can come back to this.
Would you like to demonstrate, just talk about it?
I'll talk about here, then I'll go down.
Yeah, okay, that's fine.
What do you think?
I think that's great. You'll get,
I don't want to impose on them because they're
it's their
good
first
teachers.
procedure?
Yeah, they're good teachers.
Yeah, that's it. But I was thinking
Oh, kind of it.
So you guys can have a seat, and you're going to be seeing the live demonstration here, and you can talk to Paul, and he'll walk you through the different steps or where the problem is. Then we have an expert faculty in this room. If this can happen, Paul, I think I should tell them that if your patient, because we've selected a very benign cases, but you never know. We might go inside, find something that obviously we cannot do a workshopping. We'll get that we feel that maybe he's just not able to tolerate the procedure the same way. That does happen very rarely. We'll have a backup for you. So should we move these people out of the way so they can see the screen better? Or will you want to go back here?
Go back here, we can go over here.
And I would like to see that again later.
You did that.
I want to do it.
feel the stiffness.
That was nice.
You can do this.